السلام عليكم ورحمة الله وبركاته. طلاب كلية الطب المرحلة الثالثة. معكم دكتور حيدر سعدون, consultant physician. Today we will talk about approach to the cardinal manifestation of the diseases, and our topics will be dyspepsia. What's dyspepsia? This vague term could be indigestion, bloating, early satiety, nausea, vomiting, epigastric discomfort, fullness, stomach upset, heartburn, stomach ache, queasiness. All these terms could be referred to dyspepsia. Everyone know what is dyspepsia, but no one know what to call it. There is multiple definition for dyspepsia. But what about room criteria? In order to make it easy for you, you should have room criteria for definition. It is pain or discomfort in midline of upper abdomen, and it is negative feeling which can be characterized by fullness, bloating, early satiety, and nausea. It occurs about 25% of population per year. 25% seek medical attention, and 5% primary care physician work. Dyspepsia could be functional, could be structural, and could be non-GIT cause, like cardiac cause and musculoskeletal cause. What about structural dyspepsia? Structural dyspepsia has many causes. The first is GERD, gastroesophageal reflux disease, and usually due to reduced lower esophageal sphincter tone. Many causes for it, like smoking and obesity, and other causes by medication. Ulcer, at the top of the list, is H. pylori infection, Crohn's disease, non-steroidal inflammatory drug side effects, Zollinger-Ellison syndrome, and etc. H. pylori per se as a cause of dyspepsia, and some side effect of medications like nitrate, calcium channel blocker, theophylline, tobacco, and even caffeine. Functional dyspepsia is defined as more than 3 months dyspepsia without an organic cause, also known as non-ulcer dyspepsia or idiopathic dyspepsia. Appropriate evaluation using standard diagnostic tests reveal no abnormality. The functional dyspepsia occurs in about 60% of cases of dyspepsia. What about pathogenesis of functional dyspepsia? Functional dyspepsia, it could be due to mucosal inflammation by H. pylori. It is found about 30-60% of patients with functional dyspepsia, and this is proved by tissue biopsy. Gastric acid secretion in response to gastric pleasing peptide will be high. Disturbed motor function, motility disorder, 40% of patients having gastric emptying, delay gastric emptying for solid, and similar number have enteral hypomotility after meal, and these commonly seen in patients with autonomic neuropathy and mainly in diabetes. Disturbed sensory function, central nervous system disturbance. At the top of the list is anxiety and depression. Other causes of functional dyspepsia is physical and mental well-being, reduced physical and mental well-being. Like stress, any stressful condition can cause dyspepsia, severe stressful condition. Dietary and environmental factor. Some patients with functional dyspepsia complain from specific food intolerance, like coffee, which occur in about 50% of patients induce dyspepsia. Aspirin and NSAIDs, also a well-known recognized cause of dyspepsia and even chronic peptic ulcer disease. Smoking, ethanol, are not important risk factor for functional dyspepsia. So ulcer-like dyspepsia, dysmotility-like dyspepsia, nocturnal pain, localized gastric pain, heartburn, retrosternal pain, nausea, postprandial bloating, early satiety, and worse with food. All these sign and symptom comes together and make the diagnosis of functional dyspepsia. What are features that raise alarm in patients with dyspepsia? It means what are the features that make you dig in the history of this patient and make you suspect there is underlying serious pathology in those patients with dyspepsia. First of all, weight loss, could be malignancy. Recurrent vomiting, pyloric obstruction, could be CA stomach. Occult or gross GI bleeding, malignancy, CA colon. Jaundice, alarming sign, CA pancreas. Palpable mass or adenopathy, lymphoma, CA pancreas. Epigastric tenderness and abdominal distension, could be intestinal obstruction. And rare causes of dyspepsia. Dyspepsia occur in systemic diseases like diabetic mellitus and hypercalcemia, hypothyroidism, ischemic heart disease, the same dermatome, especially patient with inferior myocardial infarction, they have epigastric pain, especially in elderly. Intestinal angina, obstruction of the vessels of the small or large intestine. Atherosclerosis, the commonest cause. Colonic cancer, gastric lymphoma or sarcoma. So in brief, dyspepsia, are there alarming feature? Yes, go ahead for OGD, endoscopy. No, is your age more than 55? Endoscopy, less than 55? Test for H. pylori. If it is positive, treatment, resolve, no need for follow-up, treatment, not resolve, endoscopy. If it is negative, treat symptomatically. So step 1 in the treatment is history and physical examination, risk factor and past history, smoking, drug use, ethanolic, previous history, personal history, history of GI bleeding, diabetes, hypothyroidism, colitis, and anxiety, previous OGD or any pathology in the GIT system. History and physical examination, peptic ulcer disease, past history of ulcer. As you know, peptic ulcer disease characterized by periodicity, period of severe pain, abdominal pain, relief with eating. Most likely this is duodenal ulcer aggravated by eating. Most likely this is gastric ulcer, and these attacks of pain resolve for 2 to 3 or 4 months and then recurrent again. So this is periodicity of peptic ulcer disease. GERD, heart pain or regular symptom aggravated when supine and coughing. Gastric cancer, 50% and above of age. Weight loss, dysphagia, history of smoking and long-standing GERD. Long-standing gastroesophageal reflux disease can cause paratesophagus, metaplasia in the esophageal mucosa, and even CA esophagus. History and physical examination, any history of biliary tract disease, episodic right upper quadrant pain more than 1 hour associated with meal, postprandial, this is most likely associated with biliary diseases or biliary stone. Medications, iron, non-steroidal, other antibiotics, let us say the augmentin, common antibiotic causing epigastric upset, clavulanic acid, and amoxicillin, and iron at the top of the list as a cause of gastric upset. Metabolic causes like diabetes, hyper and hypothyroidism, hyperparathyroidism, all these lead to motility disorder and they can cause dyspepsia. What about IBS, which is irritable bowel syndrome? Room criteria: pain relief with defecation when you pass stool, more frequent stool at onset of pain, abdominal distension, passage of mucus, sense of incomplete evacuation. Patient after passing stool, he feel he's incompletely evacuate his rectum. So these are room criteria for IBS, irritable bowel syndrome. What about examination? Fever, weight loss, hypotension, tachycardia. These are significant features of underlying pathology. Fever, infectious cause should be excluded. Lymphoma, weight loss, malignancy should be excluded. Hypotension, you should search for volume depletion and electrolyte disturbance. Abdominal examination, epigastric pain and tenderness could clarify underlying surgical cause of abdominal pain. palpable mass, malignancy, distension, IBS or intestinal obstruction, colonic tenderness, ischemic colitis, jaundice, biliary and pancreatic disease, Murphy sign, acute cholecystitis, and stool for occult blood to exclude malignancy, especially CA-cecum, carcinoma of the cecum, in which the presentation will be dyspepsia, weight loss, and occult blood in the stool. Anemia, sign of anemia. So any patient with dyspepsia and anemia, you should search for the underlying pathology. This is a red flag for patient with dyspepsia. Brittle nail, cheilosis, loss, angular stomatitis, and dryness of the mucous membrane of the tongue, pallor, palpebral mucosa or nail bed. You should examine for anemia, sign for anemia. Teeth, loss of animal, hypocalcemia, sign of malabsorption like celiac disease, lymphadenopathy, Virchow's node, CI stomach or lymphoma, acanthosis, nigricans, hyperthyroidism. Acanthosis nigricans is hyperpigmentation affecting the neck and axillary skin, and usually it is associated with CA stomach. Step 2, could the patient have cancer? So the first thing to exclude is a red flag. It is age more than 45. There is weight loss, bleeding, anemia, dysphagia, which is difficulty in swallowing. This need all these red flags. This means that this patient needs further investigation and assessment. Treatment for non-ulcer dyspepsia. Treatment of H. pylori. There is multiple regime for treatment of Helicobacter pylori. The most important one, or the easy one, or the most important regime with high cure rate is lansoprazole 30 mg twice daily, clarithromycin 500 twice daily, amoxicillin 1 gram twice daily, antibiotics for 2 weeks, proton pump inhibitors for 2 months. What if H. pylori negative? Minimal evidence support. H2 blockers, proton pump inhibitor, prokinetic agent like metoclopramide, cisabride, not recommended nowadays, can cause prolonged QT and cardiac arrest. Metoclopramide, which is Placil, domperidone, motilium, this prokinetic agent can enhance gastric motility. Step 4, endoscopy, and step 5, post-endoscopy management. What are the post-endoscopy management? Non-pharmacological treatment. Quit smoking, stop or reduce caffeine, stop or reduce ethanol, hold medication with side effects like NSAIDs, aspirin, avoid food and other factors that precipitate symptom. Better eating habit, do not eat late before sleep. Therapy for stress and anxiety, depression means consultation for the psychiatrist, elevation of the head of the bed. Why? In patient with reflux esophagitis, in order to decrease the reflux of acid to the lower part of the esophagus. Stress-induced activity, exercise, relaxation, and the most important one in the treatment, as you notice in the functional dyspepsia, is stress and anxiety. At the top of the cause is reassurance. You should reassure the patient that your symptom is not serious, and these are related to dietary habits or psychosocial abnormalities, and you can be cured early. Thank you very much for listening.